Good morning. The program is about to begin. I request all students to please put your mobile phones on silent. You're not allowed to take any pictures inside the auditorium. Please maintain silence. Thank you.
Hello everyone. Welcome to the National Conference on Emerging Trends in Allied Health Sciences, Intervention for Sustainability of Human Health, organized by M College of Health Sciences. He who has health has everything, and he who has hope has everything. Thomas Carlyle. A very good morning to everyone present over here. I am Anand Sundar from first year BSc Medical Laboratory Technology.
And I am Yuveda, second year Dialysis Technology.
We are delighted to be your anchors today. We're excited to see so many allied health students come out here to the conference and speakers who are delegated for educating the next generation of health professionals. This conference is built with an intent of active and interactive learning. We sincerely hope that ideas and views shared during the interaction will sow its seeds for a sustained fruitful result. With this idea, right planning and hard work, we were able to bring this conference into a reality. We strive to make this conference experience as enjoyable and informative to all. As a courtesy to others, I kindly request to keep your mobile phones in silence and please refrain from distracting others by excessive movements and conversations. Please note, photographs and selfies are not allowed in and around the auditorium. In general, we ask all to be respectful to the speakers, your fellow attendees, coordinators and the volunteers.
May I now request Dr. Ganesh Kumar, Dr. Raju George and Dr. Deepa C. Philip to kindly occupy the chairs on the dais. Prayer works wonders. Let us all rise up for the prayer song, followed by a prayer by Reverend Father A.B.M. Chako, Senior Chaplain, M. Please keep standing till then.
Check, check.
We welcome you, Dr. Lakshman Das. Please occupy the chairs on the dais.
Sorry.
Give thanks with a grateful heart. Give thanks to the Holy One. Give thanks because He's given Jesus Christ, His Son. Give thanks with a grateful heart. Give thanks to the Holy One. Give thanks because He's given Jesus Christ, His Son. And now let the weak say, I am strong. Let the poor say, I am rich, because of what the Lord has done for us. And now let the weak say, I am strong. Let the poor say, of what the Lord has done for us. Give thanks.
Let us be silent for a moment. Let's close our eyes and see the divine presence in and around us. In this moment of silence, bring the face, image of God to our mind. Let us submit ourselves before God. Let us submit our institutions, our healthcare workers, our projects, our families, our teachers in the mighty hands of God. Let us open our inner eyes to see the divine. Let's pray. Heavenly God, creator and sustainer of all creations, we come before your grace to give thanks and praises. We thank thee for the blessed morning. God the creator, the universe in which we live is an extension of your love. We understand it as an expression of your love and care for the human beings. We understand that we human beings are extension of you yourself, Lord. All the scientific inventions are your grace. Thank you, Lord, for enabling us to use the talents and the technologies you have provided for the betterment of the humankind. Lord, we are submitting this national conference in your mighty hand. Gracious Father, we pray for this conference and the theme, Emerging Trends in Allied Health Sciences, the intervention for sustainability of human health. Bless us to learn and understand how do we able to sustain the human health. How do we able to do the interventions? Gracious Father, we pray for all the speakers, the scholars, all those who are attending this conference. Bless each one of them to ignite the wisdom and thoughts of the young minds. Gracious Father, we pray for all the delegates who are attending these sessions, all the students and faculty, non-teaching staffs from different colleges. Bless each one of them to take away the great thoughts which we are discussing here today, Lord. Father, Lord, we pray for the Madras Medical Mission as a whole. We submit the College of Health Sciences into your mighty hand. We pray for our administrators, our CEU, our principal, the teaching staffs and non-teaching staffs. Blessed Lord, we thank thee for their wonderful families. Lord, we pray for our students and their families, Lord. Bless each one of us and our families for a wonderful future, Lord. Once again, we are submitting the Madras Medical Mission, especially this conference today in which we are gathered together. Bless all those who are attending. Bless all the speakers. Bless our future also, Lord. May we ascribe glory to you, your only begotten Son and your Holy Spirit, now and always, and forever and ever. Amen. Thank you. Please be seated.
Thank you, Father. Light fades away darkness. Light symbolizes knowledge and wisdom. To solemnize this event as a blessed one, I invite the dignitaries to kindle the lamp. I request Dr. Bharati, Associate Professor, and Ms. Anandi, Lecturer, the organizers of this conference, NCET 2023, to join them on stage. The darkness of ignorance be swept away by the dawn of self-realization. Thank you. Our hearts hold so much gratitude to this special person who is the backbone of our institution. I am glad to invite our dear principal, Dr. Deepa C. Philip, for the welcome address and to unveil the theme of the conference NCET 2023.
A warm good morning to everyone gathered here, to all the dignitaries, doctors, staff and students. I'm glad to welcome you all for this National Conference 2023. On behalf of the management of Madras Medical Mission and College of Health Science, I welcome today's chief guest, Dr. P. Ganesh Kumar, MD, Scientist D, Assistant Director, ICMR, National Institute of Epidemiology. Welcome you, sir. I welcome Dr. Rajiv George, CEO, Madras Medical Mission, Dr. Lakshman Das, Senior Consultant, Cardiology, Head of Cardiac Cath Lab. I welcome Dr. Dinesh Kumar, Senior Consultant and Medical Superintendent, who will be the judge for our presented paper presentation and chief guest for the valedictory function today. I welcome Dr. Suresh Kumar, Senior Consultant, Infectious Disease, Madras Medical Mission, who will be the judge for the poster and the paper presentation. I thank you all for sparing a few hours for this conference from your busy schedule. I welcome Reverend Father A.B.M. Chaco for his prayer and blessing us. My special welcome to our guest speakers for the conference today, Dr. Krishnaja U, Assistant Professor, Department of Community Science, Kerala Agriculture University, Dr. Badrinath Aditkalu Kupuswamy, Professor, Internal Medicine, Sri Manakula Vinayaga Medical College and Hospital, Dr. R. Subhashri, Head of the Department of Counseling and Psychology, Madras School of Social Work. I welcome all the doctors of MMM, the staff, delegates, researchers, students, and professors from CHS and other colleges who have come to attend this conference. I'm so happy to mention that we have about more than 500 delegates who are attending this conference today. This reflects the thirst, the enthusiasm, the interest to search for new trends and knowledge for the betterment of self and for the society. It gives me immense pleasure to reveal the heading of the conference, Emerging Trends in Allied Health Science, Interventions for Sustainability of Human Health, NCET AHS 2023. It's an annual academic program of Madras Medical Mission College of Health Science, which we are assuming after 2 years of COVID. Perfect example of health system that gave away for the new trends in human health was during the pandemic that showed the entire healthcare community how unprepared they were for a global emergency event. Since the beginning of the COVID, the entire medical sector has worked incredibly hard to prioritize advancements in patient care, including an increase in the implementation of the technology. Both patients and providers understand and appreciate the value of digital health services, and more people trust these modes as ways to get and give care. People began to really look at their own personal healthcare picture. They desired a way to actively participate in bettering their own mental and physical health daily. Usage of physical health applications, mental health applications, digitalized health records, and data storing ultra-tailored preventive measures were at peak during that period. Efforts to strengthen environmental sustainability in health system can succeed only with the active collaboration of healthcare workers. By engaging health workers in the process of creating, implementing, and managing the environmental sustainability policy, a country can have a better health environment. Health workers will be far more likely to be successful in their efforts to foster sustainability if an empowering institutional environment is put in place through the adoption of a sustainability policy. The Conference on Emerging Trends will help us to discuss and bring forward the latest advancements in the field of allied health and patient care. I appreciate the efforts taken by the speakers who have come to share their learnings and educate the young minds. I hope all the participants and the students will be benefited from this conference. I wish the conference a great success and all a lucky day for today to all the delegates gathered here. Thank you. God bless you all.
Thank you, ma'am, for your words of wisdom.
May I request our principal to welcome the chief guest, Dr. Ganesh Kumar, with a bouquet. Now I request our CEO, Dr. Raju George, to felicitate the chief guest with a Triple M memento. I request Dr. Lakshman Das to felicitate chief guest with a conference memento. I request our principal to felicitate Dr. Raju George, CEO, and Dr. Lakshman Das, Senior Consultant, Cardiology, Head Cardiac Cath Lab. Thank you, ma'am. Thank you, sir. It's my pleasure to invite Dr. Raju George, CEO, Triple M, to deliver the presidential address.
Our chief guest, Dr. P. Ganesh Kumar, the Assistant Director of the National Institute of Epidemiology and the Indian Council of Medical Research, our principal. Do I need to say anything more? And of course, the energetic and still young Dr. Lakshman Das, who runs around the hospital throughout the day. As you know, he's already seen several patients this morning, and that's why he was late. And of course, I welcome all of you, beloved students and guests. I was asked to give the presidential address at this meeting. And I was thinking what to talk about. Can you please reduce the feedback? Thank you. And I was thinking about the history of the allied health services. Before the 1900s, there were three major groups of professionals. One was the doctor, the other one was the dentist, and the third one was the nurse. These were the three key professionals. But since the 1900s, allied healthcare has developed in leaps and bounds. Today, if you look at the registry of allied healthcare, there are over 200 so-called specialities. And allied health services is a large group of qualified professionals who use scientific principles that are evidence-based. Now, they play a vital role in the country's health system by getting involved in the early detection, initial treatment, and further management of healthcare. Dr. Lakshman Das just walked in to the conference, and accompanied by him were two allied healthcare professionals, the physician assistants, who were trained in our college. They are the ones who do the majority of the work. They see the patients, they order the tests, and when the final results come, they present it to Dr. Lakshman Das, who then decides the course of treatment. In India, as I understand, the Allied Healthcare Bill of 2021 was introduced in the Rajya Sabha. And as far as I understand, it has not come into effect as yet. So once that comes into effect, every single allied healthcare professional will be registered under a professional body, so that you will have legitimacy. Just like the Indian Medical Council, which regulates doctors, and like the Nursing Council, you also will have a body, and that will make you legitimate. The trend today is about the future of allied healthcare. So what exactly can you see yourself in 10 years' time, 15 years' time? You're still young in your allied healthcare. The Madras Medical Mission, our hospital, is a classic example of where we have involved the allied healthcare professional. We had, right from the beginning, what are called physician assistants. Now, physician assistants, that is a concept that was developed in America during the Second World War, because there was a shortage of doctors, and they compressed the medical course into 3 years. And that is how it emerged. Later on, during the reign of President Kennedy, John F. Kennedy, he introduced the physician assistants into developing countries like Africa. And in the rural parts of Africa, the physician assistant is the one who actually sees the patient and decides what treatment to give, and if it is necessary to refer the patient to the district hospital. So they play a vital role in the health services. Here at the Madras Medical Mission, we have allied healthcare workers in cardiovascular, surgery, technicians. We do some of the most complicated heart operations in India. Transcatheter aortic valve replacements, we are the top in India. But assisting the experienced surgeons, doctors like Dr. Lakshman Das, there are people in the background. Without them, we couldn't have achieved them. Like people who monitor the heart-lung machine. They are technicians. And if they don't know what they are doing, it can endanger the patient's lives. Another area, as I said, the area is really vast. Another area are perfusionists, I already mentioned. Medical assistants. Now, medical assistants, whom we call physician assistants here, they do all the preliminary work. Epidemiologists. Doctor is quite well versed with epidemiology, so I will not go into it. That is Dr. Ganesh Kumar. Epidemiology. We need people to collect the data, to analyze the data. More recently, about two weeks ago, we have appointed a statistician who's doing her PhD in statistics. Now, she is of vital importance to our research department. She will collect the data analyze it, and give it to our doctors. Because evidence-based care is what we should be doing. We should not be treating people blindly. We should have the evidence to back up the treatment. Respiratory therapists, today, in places like Delhi, where the pollution is so high, we need people to address the respiratory problems. Clinical laboratory technicians, and I know many of you here are going towards that course. In our laboratory, the technicians are the ones who do the tests. Of course, these days, most of it is computerized, but you actually need to know how to operate the machines. And it is the technicians who decide whether to inform the doctor that these results are not correct. There's something wrong with the patient. Biostatistician I've already mentioned. Pharmacists. We have clinical pharmacists at M, 3 of them. What they do is they go around, look at the prescription that the doctors have made. Sometimes our doctors are extremely hectic, they're very busy, especially the junior doctors. They may make mistakes. It's the clinical pharmacist who picks that up. They are well versed with the interactions between medicines. They are the ones who pick it up. Every day, they give me a report of what happens in the hospital. In this busy world, especially in the Western world, India is getting to that stage now. We have clinical psychologists. In the US, nearly every person in a high-profile job has got a clinical psychologist because the pressures of work are so much. I was just discussing that before the conference with Dr. Ganesh Kumar, how life in India is so hectic that people just don't have time to think. They do things mechanically. And we need people like that, like clinical psychologists, and to be unburdening our problems. I was recently reading, and sorry to veer off the topic, but I was recently reading about social conditions in India. Although India is one of the world's lowest, it has the lowest rates of divorces. It has suddenly, over the past 5 to 10 years, jumped up to 60% over what it was before. Because women are being educated, they have the right to think for themselves, they are not slaves to men, unlike the olden times, when irrespective of whether you were a PhD or you were a higher qualification, you still had to clean the house and get up in the morning and cook. Things are changing in the world. I'm not saying that divorce is a good thing, and please, I'm not promoting that. But I'm just saying that things are changing. Life is hectic, and we need time for ourselves. I could go on and enumerate the 200 and odd allied health professionals, but I know you've got lots of things to do. But if you ask yourself, there are 4 things that are common for all allied health specialists. This includes doctors as well, which are common for doctors. The most important thing that you need to develop is people skills. Every day, you're working with people. They are human beings, just like you. Think for yourself. What if you were in their position? They are vulnerable. You need to be able to work with them. If I can use a single word that comes to my mind, it is empathy. Not sympathy, empathy. We should feel what the patient feels. That is the most important thing for an allied health worker. The second most important thing is communication skills. You need to be able to communicate very clearly, both with other health professionals who work as part of the team and to the people you work with. I don't want to call them patients because many a times people who come to you will not be patients. They will have come for initial diagnostic tests, counseling, and so on. So you need to be able to communicate with them in a clear manner. That's the second most important thing. The third thing is teamwork. You need to be able to work in a team. And this is something that we doctors have had to learn the hard way. Previously, the doctor was the king. The doctor could do everything by himself or herself. But now, the doctor has got to depend on other professionals. Surgery is a classic example. I might be the most brilliant surgeon, but if the heart-lung machine doesn't work, or if there's a fault in it, my surgery is of no use. If the post-operative care, I might have done an excellent job as a surgeon, but if the post-operative care, the nursing care, the technician's care, if that is not given properly, then there's no use. The outcomes might be worse. So it is teamwork that is the next important thing. And of course, largely, which is true for any profession, you need to be dedicated. You need to be sure that that is the profession that you want to be in. You shouldn't go into a profession and say, oh, I'm just here because I couldn't find anything else to do. You need to be enthused. Over the next few hours, you'll be hearing a lot of eminent speakers telling you about allied healthcare. At the end of the day, you need to ask yourself, what are my goals? Where do I see myself in 5 years' time, 10 years' time? Educationally, you would have finished your course. Do you want to go on to do an MSc, a master's degree? Do you want to go on to do a PhD? Many health allied professionals have done PhDs, and many of them are working within our hospital, and they're doing an excellent job. Work hard towards your goal. Allied healthcare is a fast expanding area with a great deal of potential. Your careers and your future is rosy. There's so much you can do in your careers, unlike in the 50s or the 60s, the 70s, or even in the 80s. I'll end up by saying this last sentence. I personally am really enthusiastic about the future of allied healthcare. You can be too. Today, you are living in the most exciting period of time in history where medicine gives a lot of importance to allied healthcare. So make the best use of it. Thank you.
Thank you, sir, for inciting the importance of the role of allied health professionals in the healthcare team. Now, I invite Dr. Lakshman Das to grace the occasion by his words.
Good morning, friends. I first of all to start the talk with thanking Dr. Diba Philip for calling me to felicitate for this occasion of the emerging trends in allied health sciences. I put it in appreciation, the MMM College of Health Sciences for this effort to bring in the physical meeting. Last 2-3 years during the pandemic, we had learned a lot of things by web meetings, but I always look for the physical meeting where I can find my friends, chat with them, and get along with them, and get up with the missed things, missed years of communication. And this gives an opportunity to improvise where you are, what your friends are doing, how you can improve upon your skills, where are the avenues available. All these things are not available with web chat or web Zoom meetings. This is a physical meeting that makes you feel that warmth of your colleague, and then you can learn much better than other web meetings. Even though web meetings are more focused, I always prefer the physical meeting where I can see my friends sometimes snoring and sleeping by the side. That also happens. And I actually felt very happy to see Dr. Ganesh Kumar, a great scientist and assistant director in ICMR. I learned from him that he has studied his graduation from the same medical college. I started my career in 1982, Tanjavur Medical College. So I think most of the time you might have not born even. I welcome you, sir, and I think you will have a good time with these students. And I saw the list of lectures by Dr. Krishnaja. She's from Trivandrum. I spent 6 years in Trivandrum Medical College and Sri Chitra. So I'm very familiar with the Trivandrum and Malayalam also. So welcome, Dr. Krishnaja. Hope you will have a very good time here with the students. And Badrinath is not a foreign speaker. He is our own student in Pondicherry Institute of Medical Sciences. I was wondering, he was put under the Professor of Internal Medicine. You are internal medicine? I thought you were heading the cardiology team. Yeah, good. It's always charming to be in internal medicine than the cardiology. When I joined cardiology in Sri Chitra, my professor, Dr. Tarakan, used to call me physician. First year, he will call me physician. Third year, he will call me cardiologist. I'm not supposed to talk anything about internal medicine. That's very fine, actually. Welcome, Badri, and I hope you'll have a good time. And always, psychology is very intriguing. Shriek, they call themselves. Shriek next door. You might have watched Apple movies. And it is always good to have a Shriek. Always, you have to always consult. I've got a friend in UK who used to consult for NHS. She's a wonderful Shriek. And then she earns the same amount of money what I earn 1 year, she earns in a month's time by talking for 4 clients per day. She works for only 4 days a week. I really want to be a Shriek than working as a cardiologist. I welcome Dr. Subhashri. Where is she? I didn't see her. So she'll be talking to you about the intricacies of the anxiety. That's very important aspect. You may not be very sure what you are doing is right or wrong. Sometimes you may feel very, lost yourself. When you lose a patient while you are treating or supporting from the nutrition point of view, physiotherapy point of view, various things. When you lose a patient, it just really hurts you because it brings in tears because it is something like your family. The patient is your family. So that aspect also going to be covered by Dr. Subhasri. And hopefully you will have a wonderful time talking to your friends, mingling with them, and then find out the future avenues of your future, and then we'll have a wonderful time. I wish you all the best for this conference. Thank you very much.
Thank you very much, sir, for sharing your thoughts with us.
I am profoundly delighted to take an opportunity to introduce the chief guest of the day, Dr. P. Ganesh Kumar, MD, who is a Scientist D and Assistant Director, National Institute of Epidemiology, ICMR, Chennai. Sir is a physician, field epidemiologist, and implementation researcher with 14 years of experience in public health research, training, and implementation. He has published more than 55 research articles in peer-reviewed journals and has worked on more than 20 funded projects in surveillance, NCD, and digital health. Please welcome him with a huge round of applause. I request our honorable chief guest to address the gathering and cast the light of his knowledge upon us.
Thank you for the introduction. Good morning, everyone. Respected principal, respected CEO, MMM, and respected HOD and senior cardiologist, my beloved senior, and respected father, and faculty who has organized this entire conference, and the beloved students, and who are going to shape up the future of this world, and especially the science. I'm a scientist by designation. I'm a scientist by practitioner. I'm a scientist by heart. So whatever comes from my thought process and as well as by action is supposed to be mandated with only facts. and we stick to the facts, we practice facts, and we also preach science and facts everywhere, wherever we wanted to promote that also is scientific facts. It's really a privilege for all of you to be here at this particular conference. First of all, we all need to agree, especially I am addressing to the students here, is we all need to agree that you have chosen a science field. Whether you like it or not, you have already married to it. There are two ways you can approach the science. You know that when I say when you are married to science means, whether you like it or not, you will be living with that. As mentioned by Dr. Raju, that it's an indicator of empowerment. You can even cut down that marriage anytime. I even mentioned it to Dr. Deepa that the increase in divorce is actually an indirect indicator of empowerment of women and the decision-making power given to the women. When we say that, it doesn't mean that we are promoting divorce, and it doesn't mean that we are promoting marriage also. It's an individual aspect of it. So when I say when you are married to the science, whether you like it or not, which means you have to practice it in order to understand it better. When you start living with this particular science, you can approach both the ways. Predominantly, when it says to allied health sciences, majorly it was seen as only a skill-oriented discipline, which means you will be given a kind of a task to complete a task. That's what I discuss, skill-oriented. So the practice of science is more of delivery of that particular skill for the upbringing the patient care. Especially it is more focused over a hospital setting. As a public health person, I see that into three divisions in terms of care: primary, secondary, and tertiary care. So this is more focused on the start from the mid of the secondary care to the tertiary care. When I say mid of the secondary care, it is early diagnosis and treatment. And tertiary care means that those patients who have landed up into terminal illness or irreversible illness, or their organ had an irreversible damage, then you need to provide the care, rehabilitate it, it has to function. That they need to lead a quality of life, both social and economic productive life. That's what the whole dictum of health has been envisaged. In that, allied health sciences is more focused on delivery of care to keep up the patient, especially those patients who are, the specialty is what I am targeting here, we have the audience here, is especially targeted those who are at the tertiary care. So when you practice the tertiary care, it's a huge gap of understanding related to the outcome of the patient, which we usually call as outcome research. This is a very big area, which is very, very big area, and in this area there is a lot of research is currently needed. When we say implementation research, we think of the strategies which will work out. When we say outcome research, especially related to the patient care, what worked, how it worked, whether that is be scalable or not. This is what to be studied. In a tertiary care setting, obviously, the specialist is the captain, okay? And the specialists steer the entire team, and the entire team has the tandem to work towards a common goal. This is how the tertiary care setting works. In this regard, when the multiple partners of the team, when they are working together, each one have their own observation part of it. I'll give an example. Say like a physician assistant. Okay, a physician assistant spends the maximum amount of time. It's almost getting replaced by a staff nurse, but a physician assistant is more in terms of like an kind of an pre-care, post-care, intra-care. It has all these things. I've been seeing the physician assistant being utilized in multiple ways. A physician assistant predominantly spends maximum amount of time within interaction to the patient. So, the physician assistant observation towards the patient's life course of the disease is maximum. You know what? This observation is very vital. when you cull out this observation into problems and what are all the possible solutions, there is a huge amount of scope for bringing out innovations. This is one true fact I wanted to say this. Let us take the same all our lives example. We all have a common life example for the current century which we are currently living is COVID-19. COVID-19 challenged every one of us. I closely worked with the government of Tamil Nadu and government of Puducherry in offering the technical support. First, I have gone for an epidemiological technical support to identify what are all the pockets, which are all the streets. We did up to street-wise analysis, where actually more COVID cases are coming, and what is the commonest source of infection. We did cluster investigations of hospitals too. And while providing that particular care, I found one important thing, that the quantum of care which could be provided for COVID-19 cannot be catered only by health department. This is very simple. I closely worked with the Greater Chennai Corporation. I was there throughout for nearly 9 months, stationed at Ribbon Building. So not only for epidemiological analysis, I built a team for analysis, for epidemiological analysis. Routinely every day we prepare that report, we send it to Chief Secretary, Health Secretary, Commissioner, so that everyone falls in the same line. Second, what we did is we worked on patient care and as well as public support mechanism called telecounseling center. We established two things. One is telecounseling center, and second we established is called home isolation patient care. When we did that, who actually helped is that majorly from allied health sciences. I don't know how many of you have worked here for Greater Chennai Corporation by any means, because we pooled volunteers from many colleges. We pooled volunteers from many fraternity. We got clinical psychologists, we got medical social workers, there are psychology specific care. We established one of the largest telecounseling center. I don't know the entire nation, but I can clearly say it's for the entire state. The whole building, the whole floor, we set up, we pooled all the resources. There were nearly 115 people, 150 people sitting there, and they were providing telecounseling care to all the patients who are coming for a panic. Okay, they call for a panic. This is what I have to do. They facilitate admissions. They facilitate post-care. They facilitate conversation with the patients. Why I am saying this? COVID-19 gave us an important lesson. Despite we have this much amount of a bigger fraternity of allied health sciences, we had a huge lacuna of people to work with. 150 people, not sufficient. At one point of time for home isolation patient care, we trained nearly some 500 people. All were working virtually. Despite that 500 number, we couldn't cater the requirement. We have to increase the number to almost closer to 1,000 on all our volunteers. For your kind information, none worked for money. At that time, it was a splendid job what we all did together, and I was really happy about it. The two important messages which I have received, and that is, the current human workforce, whichever we are thinking that it will be sufficient and the field will be saturated, no, it is a disappropriate allocation of resources. That's what I would say. There is more appropriation of allocation of resources is required, and it's a disappropriation of allocation of resources. If you want to ask me, the world is changing. Slowly it is moving from inpatient care to virtual, and it is also moving towards artificial intelligence also. Whether we like it or not, it is already there in our doors. For all these purposes, in order to execute it, we need more people. So I want to give one important positive message. If you are thinking that the jobs are not going to be there, no. You are actually digging somewhere else. The jobs are really required. You need to reshape differently. You need to reshape and reinvent or discover a new strategy in order to deliver a care. That's what one thing I wanted to say. For this, I will take an example for non-communicable diseases, especially one important project we have been working is India Hypertension Control Initiative, closely related to the specialty of this particular institution which have been practicing for many decades. In India Hypertension Control Initiative, one important fact I wanted to say here is that we supported nearly 139 districts of India. Our main goal or aim of that particular implementation research project, we worked along with the Government of India, WHO and state governments, is to better the patient care for treating hypertension at the primary care level. To be very frank, you know what are all the challenges? Drugs were not there, good BP apparatus was not there. This is the fact. This is not that Bihar or Uttar Pradesh I am trying to say. This is ubiquitous. This is still there where you can name some 2-3 better states. Still the drugs are a problem. The thing is, that's what I said, disappropriation of the resources is still happening even in this decade. A patient who could be treated at a government rate less than 200 rupees per year for all the 365 days can get prevented to come as a patient to your facility. This is what I wanted to say is your allocation of resources and what actually the capacity building to be done is not justified in our country. This is where academia can pitch in. Academia, like institutions, can pitch in on 2 important things. One is that courses which are all focusing on the patient care and as well as for improvement of human health need to reinvent themselves of different strategies than the usual strategy. Which means we started a community-based intervention program. Government of India's Health and Wellness Center, they promoted the kind of cadre called MLHP, mid-level healthcare provider, who are positioned under Health and Wellness Center, which is equivalent to a sub-center for catering to a population of 5,000. Here, for MLHP positions, many allied health professionals I have seen in the field. And they are working very closely with the government in providing primary care services in NCET, which means there is not a requirement of doctor. They are treating hypertension, they are treating diabetes, of course, in supervision with the doctor. The thing is that for follow-up, we don't require a doctor. If it is under control, they could be put on the same medications. If they are not under control, then only they need to get referred. For us, we did a modeling and recently published also and what we have seen is that when the current physician-based care is not sufficient. If we go with only physician-based care for treating hypertension, we can only treat only 8% of the hypertensions in India. And there are nearly 20 crore hypertensives are there in India, and only 10% are under control. 90% are not under control, which are all potentially your patients and clients. The 90% are not under control. Of course, the same scenario which is there in Tamil Nadu also. In Kerala also, we have seen that. 90% are not under control. Only 10% are under control. So, there are the innovations when we mentioned about in the allied health sciences, whether you like it or not, artificial intelligence is already there in our lives. There is a huge amount of innovation is happening on artificial intelligence in health, in human health. It is going to challenge a lot of our jobs and work, which means we need to really think smarter how we are going to utilize that as our tool. I don't know how many of you are aware about ChatGPT. ChatGPT is one of the tools which is a natural language processing which can write lectures, which can write papers, which can write essays, which can write just when you chop in what is the requirement. If you just give the title, it will give you some 600, really some 2000 words. It can rephrase, it can make you a tweet, it can give you anything. That is already there. But how better we can use such a kind of a tool is with us. Whether you like it or not, you cannot ban a technology. You need to marry the technology. You need to ride on the technology. That's the same way that medical technology entered, as you mentioned, that like when we have multiple technologies for say it is dialysis or it is for example in terms of your ECMO, so in terms of your heart transplant, multiple technology is being entered, but still we have to ride with the technology. When more technology is coming, the happy news is that more support is required. And the more support is required, we need more humans in order to ride that better. And that we need to equip ourselves. So as students, I wanted to say that please get updated about the technology, what is currently there in your discipline. If you are away from that and you don't like it, sorry, you are not part of it. And you are going to face a huge amount of a difficulty. Clearly mentioned, already Government of India in digital health is making a lot of progress and there is a lot of chaos also there. There is something called Universal Health Interface is going to be introduced. It is already introduced and it is going to get scaled up everywhere. Which means if a doctor is providing a care, he will be provided an ID and that ID will be linked to the patient. For a respiratory physician, then it will be linked. For a dialysis technician, that his ID also will be linked. For a pharmacist, from that pharmacy ID also will be linked. This is called UHI, similar like your UPI payments. This is going to totally change the way the healthcare is getting operated, which means all your healthcare encounters will be recorded. Huge amount of opportunity for research on that particular area. And finally, I just wanted to tell in terms of innovations, there are 2-3 areas where we could focus. One is called precision medicine. I have not seen any of the great research being happening for precision medicine, and that particular research could happen only at tertiary care institutions. Precision medicine is one area where we could take up. That's number one. The second area is that precision medicine is a tailored care, which means when patient is coming, you know about the entire history of the patient, and whatever the care we are going to provide, it has to be tailored for the patient. Understand the genetics of the patient, understand the family, understand its previous treatment history. It's more specific way of medicine. It is still at the time of a research area where we could really focus on it, and institutions like MMM can throw a lot of light on it, especially on cardiovascular health. There, Allied Health Sciences has a major role who could take a kind of a front seat and take guidance from people like Dr. Lakshman Das to steer it. Okay. The second area is on management, which is operational research. When we provide any kind of a care, when there is an organizational behavior with multiple workforce with the different disciplines and different learning, then obviously there will be a lot of efficiency issues will be there. And how to bring out a better efficiency, operational research is one area where we could focus more on that. Especially in management science, we need to embrace the management science into the hospital administration for many things where research could be done. That is also where Allied Health Sciences can take an important role, which will be needed for the institution and as well as for the fraternity. And finally, for patient-specific care, follow-up is a big gap everywhere. I wanted to say this very honestly, and it is documented everywhere. Follow-up of discharged patients, follow-up of a patient under care, follow-up of chronic disease is a very big gap. In this area, medical sociology can play a major role. How to improve the follow-up of the patient care, and also there is a lot of myths around understanding the health. And there is a lot of myths around nutrition. And nutrition is one area where is huge amount of myths is there. Sugar and salt was not seen as a major killer, whereas oil has been seen as a major killer. I don't think that Lakshman Das will disagree with me that salt is such a major killer and sugar is an important killer than oil. But we have been always vetted with our practice of understanding oil behind it, which is bad for human health. There is huge amount of myths around nutrition. We need to bust these myths, and this is where clinical nutrition can play a role. Patient follow-up care and patient-centric care. Clinical sociology medical sociology can make a huge important role. And also clinical psychiatry, mental health is growing problem. I have witnessed many of my colleagues who have lost their lives recently. They have lost their life. Despite they are inside the same kind of fraternity where there is kind of an interaction, we have lost a lot of our colleagues. And mental health is a growing program. Let us accept the problem, and where clinical psychiatrists have a major role in that. It's really a privilege for all of us to have a conversation like this. And I also hope so we need to have, all of you need to have a conversation, same between you people, like this kind of an occasion in conference. And it's an honor to sit along with such a dignitaries. And thanks for inviting me for this wonderful conference. My best wishes. Thank you very much.
Thank you, sir, for helping us know how to approach science. Your thoughts have truly inspired and motivated us. Now I request our chief guest to release the souvenir. Thank you, sir. Here we wind up with the inaugural session. We will meet after a tea break for the scientific session. I request all to move towards either sides of the auditorium for the tea. The right. Everyone, kindly be seated. I request everyone to maintain silence and discipline as it is a patient's area. Photographs and selfies are not allowed in and around the auditorium. Everyone, please be seated until further notice. After tea break, everyone can sit in their respective places. Students occupying in the right side of the auditorium can use the right door, back side door, and students in the left side use the right side door, left side door.
Dear students, students over the left row, kindly come through the left side door, this side. Don't go back. Only the right row students will be occupying the back door. Okay, please. Left row students can come through the left door.
there a Shalini Tripathi who has missed their ATM card? Shalini?
I request the audience to sit in their respective places. Requesting all the audience to sit in their respective places, we are going to start with the scientific sessions. Gentle reminder, photographs and selfies are not allowed in and around the auditorium. We welcome you back. Now, we are entering into the first technical session of today. I would like to introduce Dr. Krishnaja, Assistant Professor, Department of Community Science, Kerala Agriculture University. Ma'am has 14 years of experience in the field of teaching, research, and diet counseling. She has more than 14 publications in journal like International Journal of Processing and Post-Harvest Technology, the Indian Journal of Nutrition and Dietetics, Asian Journal of Dairy and Food Research, Journal of Pharmacognosy and Phytochemistry, and International Journal of Chemical Studies, and so on. Ma'am is an active member of Nutritional Society of India, Secretary of NSI Trivandrum Chapter, Eat Right Kerala, Net Profan Trivandrum, and Indian Dietetics Association. She has presented many scientific papers in many national and international conferences. We welcome you, ma'am. Today, ma'am will be speaking on insight of nutraceuticals in oncology. Over to you, ma'am. I request the audience to maintain silence. Thank you.
Good morning. Good morning. Yes, I need that attention. Okay, am I audible? Yes. Okay. So first of all, let me take this opportunity to thank Lali ma'am and the team who have offered me this great choice, a chance to be here and address you. I think it's a mixed group, like allied health sciences. I thought it will be mostly nutrition students, but I understand it's a mixed group. So I'll try my best to make it interesting for others as well. So, okay. So after a tea, maybe like if it was after a session, you would be all very happy to see this picture. So what is this? It's a feast. Yes? You know, see how a feast is, you know the importance of a feast or why it has been, how it has been arranged on a plantain leaf? You know how the shape of a plantain leaf is. Yes, it is actually narrow to the left and it gets widened to the right. Most of us are right-handers and we used the small quantities of like pickles, and if it was in Kerala, maybe we use inji puli inji, something like that. Then we go on to the vegetable part and finally to the digestive part also. And the rice usually is it's a small portion. So this used to be how our feast used to be in earlier days, right? Okay. So now how our feast has changed. We do not sit, right from sitting on the flat surface, we have moved to a table, and from now how do we have our food?
buffet, right? So we stand. In Malayalam, I'll tell you, there is a proverb like, say, "Erennu thinnalum ninnu thinnaruthu." That means, even if you beg and eat, don't stand and eat. So that's what we say. Okay. So, but now the concept is like we don't have other opportunities, we do this. Okay. So, and again, there's a transformation, like how we have moved from to the fast foods. Appa. So this we call as a, what is this? Paratha, I know that's paratha. This is called as a traditional food now, right? If it is in Kerala, we combine with beef curry. That is a very must. Adipoliyana, alle? Okay. So this is how the transition of our food has become. And what has this led to? This. Okay. Can you see the cancer incidence in India? You can see that we are like Kerala, no? Like not only in literacy rate or reduced MMR and IMR, we also fight for diseases also. We are known as a capital of diabetes, diabetes capital of India. So followed by Delhi, we fight for other diseases also, even for cancer. See, we are in the second place. You can see Chennai is also not behind 2 places. We are just 2 places behind Trivandrum in this case. Okay. So what are the different types of cancers? Like we have the breast cancer, which contributes most. Then we have cervical cancer, ovarian cancer, lip and oral cavity cancer, colorectal, and other cancers which comprises all these things. So what do you feel looking at this picture? I don't see any oohs and ahs, like how you had for your feast or for the paratha, right? But we'll see what are the benefits of these things. Okay, so can you read it? It says that plant foods are good sources of substances called phytochemicals. Hope you all know what is a phytochemical. Yes? Yes or no? Yes? No? Just answer, like otherwise it will be very monotonous, only me speaking to you. You know what is a phytochemical? Phyto means? What is phyto? Yes? Light. Plants. Okay, so the chemicals which are produced from the plants which are of health benefits, you have some benefits from these. Can you name something like chemicals which are produced by the plants which are helpful for us? Fats. Vitamins, minerals, many types of vitamins and minerals. Yes? Vitamin C, E, everything. You know these things. Beta carotenes. Okay. So next time whenever you have something in front of you, just think what are the nutrients in it so that you'll realize what is the phytochemicals and its health benefit. Okay? Okay, so that's what I wanted to stress, that the healthy diet and lifestyle behaviors could prevent nearly 40% of the cancer cases which has been reported. So make some changes in your diet and also in your lifestyle. So with this a small introduction, I take you to the topic of nutraceuticals and oncology, or what is its role in cancer, just an overview. Okay. So I thought you are all very much aware of what is a nutraceutical. That's why I did not want to spend much of my time on nutraceuticals. Have you heard of the term nutraceuticals? Nutraceuticals. Ceuticals at least? Yes? Yes or no? No. You don't know what is a ceutical as a pharmaceutical? Pharmaceuticals. Okay, so I think you all have vouched to be silent, so I do not want to preview into it. Okay, so for nutraceuticals, you combine nutrients for the health benefits for a medicinal property. So you have lots of kinds of a term which goes functional foods, herbal medicines, dietary supplements. There are many things which goes hand in hand with this term nutraceutical. Okay, so now let me speak first. We have two coins. Let us on the nutraceuticals and the cancer. First, I'll be dealing with the cancer part. You know, cancer is a much dreaded disease. You know why? Is it because it's incurable? Or is it because the after effects of treatment is severe in cancer? Okay, so nearly 20 to 40% of the cancer death are maybe because of improper nutritional support. Okay, so there is a great changes in the nutritional status of a patient who has been diagnosed with cancer. So unless you address the problem very correctly, so they tend to lose their lives. Okay, so that is why I stress nutrition plays a very important role in the cure of people who have been identified with cancer. Okay, you should have definitely been working in a different allied health sectors. You would have also come across people who have been cancer patients also, right? Yes. Okay, so this our main aim while treating a cancer patient or while being in an allied health sector or being a nutritionist is to maintain a good nutrition status, that is a good health status. Okay, so there is a progression of the cancer happens. So see there is a role for diet, nutrition, physical activity, and also the environmental exposures even the host factors which will contribute to the progression of cancer. Okay, so you can see that there is from the normal epithelium into an invasive cancer, there are many factors like host factors, like it can be genetic or microbiome. Your gut microbiome can be one of the reason, or the age, gender, an inflammatory state can also be the reason. Your host factor, like the reasons from our cells, which can contribute to cancer. And that can be from the other environmental factors like the foods we have, the preservatives, the additives which has been added to our food. All this can contribute as an environmental factor, and your diet pattern or the diet factor or your improper lifestyle habits can also contribute to the cancer process. So what are the challenges as a nutritionist or a health sector people do you face? That is, they'll have restricted intake. So already they are having some problems and they are undergoing many treatments like chemotherapy, radiation, or even bone marrow transplantation. So the intake will be very, very, very much restricted, and you cannot feed them larger quantities. Okay, so and even if you try to feed them, their retention rate will be comparatively lesser. So this altogether can lead to malnutrition called cachexia. Okay, so this is and you can see that this malnutrition and loss of weight loss is very common among cancer patients. So nearly 30 to 87% of the patients are identified with malnutrition, especially protein calorie malnourishment. Okay, so this is the most common secondary diagnosis for cancer patients. And it is one of the major reasons which can contribute to the morbidity and mortality of the patient as well. So this is a vicious cycle. You can see how the cancer can lead to the malnourishment. So it can be because of the anti-cancer treatments, how the side effects produced by these components leading to anorexia. That is, anorexia is lack of appetite. Okay, or there is an inadequate energy intake or expenditure, or your metabolic pathway, both the carbohydrate, fat, protein, every metabolism has been affected. All this will contribute to cachexia, that is severe malnourishment. So the type of malnourishment or the weight loss is also very critical in the survival of a cancer patient. How you manage the malnourishment. If it is gone unnoticed, definitely it will lead to more morbidities and mortalities. Okay, so initially from malnutrition, it will lead to weight loss, then muscle mass loss. Okay. So even if there is 10% loss of the muscle mass, the associated mortality is 10%. So you can see that as and when the muscle mass loss is increasing from 10 to 40%, it can even lead to death, usually from pneumonia. Okay? So you cannot always take BMI as an indicator for the muscle mass. Okay, so this is a picture of the brain which shows that, see, even the cachetic patient had the same kind of or the equal lean body mass with that of the normal and obese patient who have been identified with cancer. Okay. So what are the challenges of different types of cancer you'll be facing? So first we'll see about the different types of neck and head cancer. So usually there'll be pain. So there'll be problem of aspiration. They'll be having obstructions in their nasal cavity, and also there will be oral incontinence. It will be difficult for them to digest many kinds of food. They'll be vomiting very, very frequently, and there'll be dysphagia, also difficulty in swallowing also. Okay, so this is a kind of trismus. So they cannot open their mouth properly. There will be restricted mouth opening. So this can be because of the OSMF. Okay, and usually this is seen among people who chew betel chewing, arachnid chewing very commonly. So then next, there's a problem of aspiration, usually associated with the oropharyngeal cancers, laryngeal problems, hypopharyngeal conditions, or esophageal or GE junction cancers. Oral incontinence, usually they'll be having a problem of drooling. Even if you feed them the food, they'll be difficult to swallow, and the food will be drooling out of their mouth. And even it can be because of related to the cancer or the treatment they have been undergoing. And there can be nasal regurgitation. If you take food, instead of going into the stomach, it can get regurgitated and it can reach the nasal, and it can irritate your nasal cavity also. And this is mostly seen among post-radiation therapy patients. So dysphagia is difficulty in swallowing. There are different grades from grade 1 to grade 5. So usually, even though it is grade 1 is symptomatic, they'll be able to eat normal diet. But as and when the condition progresses, the grade 5, it will lead to death, because they will not be able to consume or swallow anything through their mouth. So there will be taste changes, there will be sore mouth, there can be dryness, there can be fatigue, edema, odynophagia, pain in this area. So these are mostly related to the head and neck cancers. So next is the esophageal cancer. So these patients are the most malnourished, because they'll have difficulty in swallowing. So that is nearly 79 to 100% of this population are malnourished. So this again, it can be because of the tumor which is present in their oral cavity, or it can be because of the operations or the radiation therapy they have been undergoing, or it can be because of a fistula also. All this can lead to dysphagia, aspiration, reflex syndromes, etc. So the cancer of the stomach and duodenum, mostly the GU, gastric outlet obstruction, the stomach capacity will be reduced. That is linitis plastica. That is a condition. You cannot take only a particular amount of food they can consume. After that, they'll be feeling fullness very, very quickly. Okay? Or there can be dumping syndrome, bilious gastritis, or obstructive. Even the absorption of vitamin B12 or other micronutrients, absorption is obstructed, or they'll be having problems with this also. There is there's a factor in your intrinsic factor which is required for the absorption of vitamin B12. Okay, so that will also not happen properly in the patients with the stomach and duodenum. So I just wanted to take you through what are the different types of the stomach cancers, like obstructive pylorus, which is associated with goo. There can be large amount of food which is retained in their stomach, which will in a long time it will become foul smelling, and it will be, even the vomit will be foul smelling. Okay, and it can lead to malnourishment and dehydration also. So not only that, they'll be having hyponatremia, hypokalemia, and metabolic alkalosis. In limitus plastica, I told you they'll not be able to hold large amount of food, or even the normal quantity of food cannot be fed to them at a single stretch. So this can be, they'll have a early satiety. In dumping syndrome, most of you should have known that, a dumping syndrome. So the food directly passes to the large intestine before going through most of the digestion process. So because of this, most of the nutrients which has to be absorbed will not be absorbed properly. So this can be because of the any obstruction or surgery which has taken place in the GI tract. So then this bilious gastritis, that is the bile is getting regurgitated. So the bile is getting regurgitated into the esophagus, into the stomach, so that it will irritate the esophagus, which will lead to inflammation. And also the absorptive deficiencies because of the malabsorption syndrome, especially of the B12, vitamin B12, because of the lack of the intrinsic factor, which can lead to many conditions, even like dementia. So next is the pancreatic tumors of the pancreatic exocrine deficiency or post-operative pancreatic leak, chronic pancreatitis, the Whipple's procedure or the diabetes mellitus or hypoglycemia. These can also lead to pancreatic tumors. So they'll be always having a feeling of indigestion. If you take food, unless you feel satiety or if the food has been digested properly, you'll always have a blotting sensation. And so immediately after you have your meal, there'll be cramps. Your stomach will start cramping, and there'll be flatulence production, large amount of gas production, and it will be mostly the stools which are passed will also be foul smelling. Okay, and it will be grassy, and it will be greasy and fatty stools, which will be floating even after you flush the toilets. So next is the ovarian cancer. So this can also have some potential role in the nutritional impact. So it can be, the complications can be from the surgery or because the bowel obstruction, because of nausea, vomiting, or the stools which are not in their right consistency, or because of the inadequate intake of the right kind of nutritions. So next kind of cancer is the liver and gallbladder. So this is because they'll be facing limited food intake because of the ascites, inflammation of the liver, or the water gets accumulated, the inflammation to lead to steatorrhea, and there can be anorexia, vomiting, and also hypoalbuminemic conditions. In colon cancer, so if there is any obstruction in the path of the colon, you'll need to treat them with the right kind of interventions like surgical resection or colonoscopic stenting. Even when you go for colostomy and ileostomy, there can be chances of an imbalance in the electrolyte and fluid balance. And the large bowel deficiencies are mostly the malabsorption syndromes of vitamin B12, iron deficiencies, bile absorption deficiencies, fat malabsorptions, and also vitamin E, D, E, K deficiencies. So the chyle leak, where the fluid gets depleted and lead to malnourishment. Okay, so in the chyle, the protein, lipids, fluids, electrolytes, and other substances get leaked into the chyle. So usually we suggest them with fat-free diets, but it is not. You cannot continue that for a very long time. It's just a temporary diet which can be followed only for a couple of weeks. And the last one is the hematological conditions, types of cancers, where there can be AML, CML, or mostly the people will be having anorexia and weight loss. And even if it's among children, it will be very difficult to feed them because already they are in their growing stage, and the nutrition part, if it is not taken care of properly, you need strength not only to fight the disease but also to overcome the side effects of these chemotherapy as well. Okay, so mostly these people will be having taste acuity, the changes in the taste acuity will be changing, nausea and vomiting, and the complications which have been followed by the BMT, that is bone marrow transplantation. So this I have already addressed. If it is a pediatric condition, so especially there will be fatigue is the most common thing seen among children with cancers, especially already they are restriction. There is restricted movement. They are already in a hospital setup, and they are psychologically depressed. So all this can lead to an aversion to the food. Whatever kind of food you give them, they'll be having an aversion to what you feed them. So the hospital setup itself. So nowadays the situation has changed in many hospitals. You can see that it is a team working together so that they make the patients feel at home, right? So that is how now the department is working, right? Yes, sir, the hospitals. So there can be problems of radiotherapy. Okay, so now why I've discussed, or why I wanted to give you about the different types of cancer is that we can, to a greater extent, the role of nutrition or the right kind of diet plays a very important role in at least overcoming the issues or the side effects of these problems. Okay, you know that the nutraceutical industry, India's nutraceutical industry has been growing at a very fast rate. Okay, so this is the one I told you, the nutraceuticals, the different types of nutraceuticals, the functional foods, the micronutrients, dietary supplements, terpenoids, polyphenols, glucosinolates. There are many kinds of nutraceuticals in the market nowadays. So, but they'll have, maybe it comes in very different names, but they are all mostly the same. Okay. So I wanted to ask you, why are we focused on this nutraceuticals? What is the role of nutraceuticals in this oncology? You can see that how this picture clearly shows you like how the nutraceuticals in its role in cancer prevention or treatment or management. You can see that there are different types of nutraceuticals. There are dietary fibers, fatty acids, carotenoids, vitamins, minerals, probiotics, prebiotics, and also many phenolic components. All this which is called as phytochemicals. So what is their role? What is the mechanism of action? It is this. So these nutraceuticals are found to inhibit the cell proliferation. Remember the first one or two slides to show you how the cancer progression happens. So this nutraceutical, the mechanism is to prevent or inhibit the proliferation of cells and differentiation, proliferation and differentiation, and also the inhibits the efflux passengers or the genes which it can trigger or the formation of this oncogenes, and reduce the toxicity of the chemo drugs, therapeutic drugs. So this is the aim of the nutraceuticals. So especially you can see there are many types of phytochemicals like from tocotrienols, tocopherols. You can mainly get them from having grain, cereals, rice, wheat, maize, corn, etc. Okay, so their main role is to suppress the growth of the oncogenes or the oncocells or the tumor cell lines. And carotenoids mostly are found to be working as an antioxidant. Keep this point, antioxidant, in mind. We'll get back to that in a few minutes. Okay, so that is fight against many cancers like uterine cancer, prostate, colorectal, lung, digestive tract disease, cancers especially. Then there are limonoids. Limonoids are mainly from the citrus fruits. They inhibit the phase 1 enzymes, that is, which will activate the oncogenes. And the phytosterols, they have anti-inflammatory and anti-neoplastic functions, especially its role in cancer. Then phenolic constituents, you can see these phenolic constituents in many plant sources, and their main role is its role as an antioxidant. Then you have flavonoids, catechins, and gallic acids, isoflavonoids, all playing a similar but very effective roles. Even anthocyanidins, glucosinolates, indoles, fiber. So I just one or two, I'll show you how the nutraceuticals, or how the therapeutic role of nutraceuticals in cancer, especially the colon cancer. So like I'll give you the examples like dietary supplements. Even see beta vulgaris, it's beetroot. That even has an effective role to control cancer. Then the olive oil, citrus fruits, green tea, then plant secondary metabolites. So these secondary metabolites are produced by the plant for its own function, like it may be to fight a disease or to prevent some foreign invasion, but that has been very useful for human consumption and cancer treatment, like flavonoids, phenolics, carotenoids, alkaloids, etc. Then you have medicinal herbs, microorganisms also. I told you the gut microbiome, maintaining your gut microbiome, which is called as a second brain, is very important. So this can help you to prevent or manage cancer. So this is it's a table which shows you how different nutraceuticals have been used for the treatment or the progression of colon cancer cells. So there are many studies associated. These are all scientific studies which has been proven effective in the cancer cell line treatments. So see again, this is a dietary nutraceuticals for anti-colon cancer and preventive, which can be used as a preventive medicine. Anti-cancer, colon cancer, and preventive medicine treatment. So this is a review article actually which came in the Cancer Genomics and Proteomics. Actually, if you are interested, you can just read through this article. It is very interesting. It shows that the anti-cancer effects of nutraceuticals in the Mediterranean diet. There are many diets which have been promoted recently. Yes, any diets which you know? The most famous keto diet. Yes, keto diet. Everyone knows of keto diet. So again, is the Mediterranean diet has also been very famous, and for control of many diseases, this diet has been recommended even by many of the dietitians. So it's because it's nothing like you counsel them to have lots of fruits and vegetables, which has been included, and also olive oil, which plays an important role, or substituting with other oils. Okay, you can see that this shows that about the epigenetic diet. Have you heard of the term nutrigenomics, nutrigenetics? At least nutrition students? Nutrition students, can you just raise your hands? No, you don't know it. Upstairs. Okay, have you heard this term? Nutrigenomics, nutrigenetics. How are both the same or different? Both are same or different? Different. Okay, at least I got one answer. I'm happy. Nutrigenomics. So the one is how the nutrients control the genes, and the other one how the gene controls the nutrient absorption or their metabolism. Okay, so there is another term called epigenetics. Okay, so there is the role of the environmental factors which will play the role in the nutrigenomics and genetics. So this is an epigenetic diet that is mostly popularized among, so now it is becoming popular in India as well, but this is usually used by the Western people. So this article shows an association between the proper nourishment and the development of various cancers, such as colon cancer, breast cancer, prostate cancer, etc. So the bioactive compounds, that is what I told you, the phytochemicals in the food, how does it play a role in cancer prevention? That is, it controls the DNA repair, it plays a role in the hormonal regulation, in the cell cycle, it controls the cell cycle, apoptosis, that is programmed cell death, and also differentiation, cell differentiation. So you can say that diet plays a very important role or an influence on the genetic and epigenetic factors which is associated with the cancer progression. Okay? So this, you can see that is in a prostate cancer, how the nutraceuticals, see, you can see this, the efficacy in the many nutraceuticals like silibinin, the grapeseed extracts, the carotenoids, soy, green tea, selenium, even the vitamins like vitamin D, E, can play selenoproteins, vitamin D. All this can play an effective role in the chemopreventive or nutraceutical properties in the disease management. Okay, this is the one I told you about. You know what is an ROS? Have you heard what is an ROS? Yes? Reactive oxygen species, very good. Okay, so what is a reactive oxygen species? Is it good or bad? Bad. Good. No answer. Better. Okay. See, the reactive oxygen species, especially the free radicals. So it is the oxidation process, you know, it is a very normal process which is happening in your body. Do you know that? Yes. So that when it goes uncontrolled, only then it will lead to many of our diseases, okay, metabolic disorders. So when there is an imbalance, if it is when the reactive oxygen species has been produced by your body, and if you have enough antioxidant which has been inert or which can be got from your food or through the diet, there is a balance between two, the modulation of the cellular signaling pathway or the lipid DNA proteins. When there is an imbalance, it will lead to oxidative stress. Okay, can you see this? So when there is no antioxidants, this balance will be lost. Clear? Clear. So you know the role of nutraceuticals or antioxidants. So this is how the microRNAs, so they are the ones which triggers the cancer producing genes. So how they are involved in the or the carcinogenic process. So there can be the microRNA. So when you have enough amounts of phytochemicals, they have control on the microRNAs, and thereby it will signal it will have a control on the carcinogenesis process. It can be effective in the anti-cancer treatment or regulation of the gene expressions. The way when you have a cancer treatment, where the targeted and cancer treatments or the biomarkers which has been which is used for the diagnosis or the prognosis of the cancer, all this can be monitored with the help of the phytochemicals which we consume or which can be even substituted as supplements. So next, I also have a question. So you know that the natural antioxidants, which has been either produced by our body or maybe which has been supplied through the diet, why do they not become toxic even after scavenging the free radicals? I mean, after scavenging and converting to free radicals, why are they not becoming toxic? And antioxidants. So oxidation, it is preventing the oxidation process. So continuously, even after doing this, why it is not becoming, and why is it not becoming toxic? So can you see this? See, this RO, even the cancer cells produce this reactive oxygen species, ROS. Okay? So that what happens is there is a term called pro-oxidant. Have you heard the term pro-oxidants? Pro-oxidants are something which gives an oxygen for oxidative process. But earlier, or for antioxidants, so this part of the left side of this picture shows you how an antioxidant treatment can be effective in giving you a health, or how it will reduce the cancer progression. While on the other one, you can see that the pro-oxidant treatment, so pro-oxidants are also used for treating cancers, just like antioxidants. Because after a particular period of time, even the antioxidants will start behaving like pro-oxidants. Okay? So why? That is the two phases of the ROS in cancer. The two phases of ROS in cancer. Okay, so can you see this? How the ROS, which is appreciated for the cellular signaling capabilities, have a dual role in cancer. On the one hand, it can promote the pro-tumorigenic pathways or signalings, which will facilitate the cell proliferation in cancer formation. On the other hand, it can promote anti-tumorigenic signaling and trigger the oxidative stress-induced cancer cell death. So this is the dual role of ROS. Then how can we say what is the limit? What is the quantity of antioxidant that you can use? Or even whether ROS is good or bad? See, can you see this? See, so these are you should have all heard of this NOx, COX, LOX, all this some substances, which how it will be how the balance of the cells is lost and leading to cell death. What is the role of the antioxidants which is being produced by the cells and the mitochondria? See, so these are some of the ROS generators, oncogenes. So the loss of tumor suppressor cells, or there is too much of metabolism, hypoxia, less amounts of oxygen, low glucose. On the other hand, the scavengers are glutathione peroxidase, sodium mutase, cytochromes. There are many ROS scavengers, free radical scavengers. Only when there is a balance between these two substances, you can maintain a healthy body. Okay. So now I'll tell you what is a possible harmful or beneficial effect of an antioxidant compound. What is it dependent on? I told you, how can we decide what is the limit of antioxidants or nutraceuticals that you need to take? How can you decide that? Or what decides it? It's concentration. How much of nutraceutical, a particular nutraceutical you've been taking, or a phytochemical or an antioxidant you have been consuming. Or there are other antioxidants which will interfere with its metabolism. Or it can be the endogenous antioxidants which are produced by our own body. All this can which can have a negative or positive effect on the role or the possibility of these nutraceuticals in treatment of many diseases, especially cancer. The concept behind this is synergism or sparing effect. You take, that is why we always say, never go for an isolated component. It is always good to have which is good to have food, get your nutrients through food, or take supplements. Food. Why do you say so? So there are many factors, right? So then rather than taking an isolated component, when you take food, you get lots of nutrients from it, which will play a synergistic effect which will have a positive and negative role which will control or increase the effect of one nutrient or the other. So that is why you say food is thy medicine and medicine is thy food. Famous quote of Hippocrates. Okay. So the additive and the synergetic effect of this antioxidants or phytochemicals or nutraceuticals, whatever you call them. So always go, instead of having one single nutrient, go for a combination of nutrients, especially try to have it through the food. So these are some of the experimental studies of the different nutraceuticals, and when they were taken in as a single form and when they were taken in a combined form, especially by the treatment of chemotherapy. You see that when vitamin C was taken in alone, it was showing an increased ROS, sorry, anti-tumorigenic effect, and without any meaningful toxicities to normal cells. But when they were combined with chemotherapy, so when you combine alone, the medicine alone, along with the chemotherapy and the nutraceutical combined together, how it is effective. You can see that most of the cases, the studies reported that along with chemotherapy, when we are combining with other nutraceuticals, the outcome was better. So these are many different like eugenol, genestin, gingerol, quercetin, resveratrol. There are many components which has been isolated and treated alone and along with chemotherapy and chemotherapy alone. They have done many studies. So, okay, now I want to, like, within 5 minutes or 10 minutes, I'll be winding up my session. So, I just wanted to introduce, have you heard of nanotechnology? Food nanotechnology? Food nanotechnology. So, you know that you are minimizing the size and making its effectiveness, improving the effectiveness of a molecule. That is mainly the nanotechnology. So, especially if it is in a nutraceutical delivery system, when you use nanonutraceutical technology. Okay, so the main role is, so instead of you have a vitamin, maybe nowadays we are using food nanotechnology for targeted outcomes. So you aim at a particular place, or you want to treat with a particular point. If you are having some deficiencies, for example, if you have vitamin D deficiency, you use nanotechnologically produced components in your food supplements, they will directly work on the bones. Okay, similarly, if they want something to be treated on for your intestines, you can use this nanotechnology. So the same rule has been applied for the nutraceutical delivery system also. So mainly it is the main role is improvement in the bioavailability. So whenever it comes to the phytochemicals, especially the plant-based chemicals, the bioavailability of the product is a problem. Okay, so since I told you there can be a lot of hindering factors which can reduce the bioavailability. So when you use nanotechnology, the bioavailability of that product has been improved. You can also, there is a co-delivery of other components also, and you can have a targeted delivery, controlled release, instead of releasing it in a single, like so how we use the insulins, different types of insulins. You can have a controlled release, the side effects can be reduced, the solubility can be enhanced, and also the shelf life of the product can be prolonged for a very than the normal products. And you can maybe sometimes if you have some drugs, maybe it is not very appealing to you. You can influence the aroma and flavor of the products also. All these are the benefits of using nanotechnology in nutraceutical delivery. Okay, so it is being used for many kinds of lifestyle diseases, like for anti-cancer, it has anti-cancer properties, cardiovascular diseases treatment, antioxidant, anti-inflammatory, antimicrobial property, all this in the form of a nanocarrier. So in nutraceutical delivery, when it is through the therapeutic action is not achieved when you give the nutraceutical alone. When it is in the form of a nanocarrier, the therapeutic action is better. Okay, so these are the different nano carriers which can be used in the nutraceutical industry. It can be in the form of emulsions, gels, or permeation enhancers, or it can be in the form of phospholipids, that is non-deformable vesicles, nanosomes. Then these are the different forms of nanoparticles or nano carriers which can be used in the dietary supplements or the nutraceutical industries for the delivery of the drug or the nutrient. Okay, so this is the first picture. Remember I showed you how the nutraceutical helps in the cancer prevention and treatment. When you are using nano carriers in different forms, the results have been found to be better. So in the forms of nano formulations, the enhanced performance of the cancer drugs were also found to be more effective when they were used in the nano forms, and their controlling powers were also increased. Okay, so this is hopefully my last slide. What is the role of cancer or nutraceuticals in cancer research? So it can be very promising. You can see, you saw that nanotechnology can be used as a nutraceutical in the nutraceutical industry, not only as a food form, also for the delivery of the drugs also. So it can be having a targeted output, more sensitization. So without altering the change or bringing changes in the host cells, you can make make it effective. But the challenge is again the bioavailability, which can be again overcome by the use of the nanotechnology process in the nutraceutical delivery system. So with this, I want to just end my a small session, say, let's put life into their days, not just days into their life. So you all being from the nutrition background or the allied health sectors, so it is our role or responsibility to put life into the days, whatever is left to them, and not just days into their life. They may be having just a week, maybe a month, maybe a year, maybe, but it is our role or responsibility to add life to those days. So treat them properly with care. I remember like all the eminent speakers who have discussed in the morning session, show them empathy. It can be even when you're serving, when you go to the hospitals, being dietitians or nutritionists or any people who are working in different sectors, show them the empathy. That itself will create a kind of they'll feel like they belong to that place, or they can be cured of these diseases. So that itself will give them hope. And definitely that will bring about positive changes in their life. So once again, I take this opportunity to thank the whole team of Triple M for giving me this opportunity. Thank you.
The audience are welcome to put forward your queries.
You have any doubts? We are not of that type. நாங்க அந்த type இல்ல ma'am. நாங்க அப்படிப்பட்டவங்க இல்ல. That is what you want to say, right? Any doubts? Okay then, thank you.
Thank you very much, ma'am, for sharing your profound knowledge with us. Your session was full of zeal and valuable information. Now, I request our principal to honor Dr. Krishnaja with a memento. Thank you, ma'am.
It's now my privilege to introduce Dr. Badrinath. Dr. Badrinath Attagulu Kupusamy, Professor of Internal Medicine, Sri Manakula Vinayagar Medical College and Hospital, Pondicherry. Sir holds more than 20 years of teaching experience for both undergraduate and postgraduate students and patient care. His areas of interest are preventive cardiology, cardiorespiratory diseases, women and heart diseases, non-communicable diseases, pulmonary hypertension, sleep disorder, breathing. Sir has 39 publications in journals like International Journal of Advances in Medicine, Journal of Medical Science and Clinical Research, Indian Heart Journal, Journal of Indian College of Cardiology, and many more to his credentials. We welcome you, sir. Sir will be presenting on the topic cardiac emergencies. May I request the audience to maintain silence? Over to you, sir.
Happy morning. Okay. First of all, let me take this opportunity to thank the organizers and my teachers, Dr. Rajan sir, Dr. Ajit sir, and Dr. Elan sir, and of course Dr. Lakshman Das sir. So my topic is cardiac emergencies. I really thank that organizers, they have chosen this topic, which is common for all specialties. You cannot escape from these cardiac emergencies, okay? Whichever field you are, okay, and both the topics. So I really congratulate organizers for choosing this topic and addressing me to deliver the lecture. So we know that cardiovascular disease is a leading cause of death globally, and 1.79 million deaths of cardiovascular disease. This for as far as 2019, and up to 30%, 32% of global death. Of these 32%, 85% are cardiovascular, that is acute coronary syndrome and stroke. Cerebrovascular accident. Over 3/4 CVD deaths takes place in low and middle income people. Why it is so? In Western countries, they know that what you call healthcare hazards. The quality of life is different. Where I will not say the literacy rate, even though we know that these things harms our health, we are fond of that food, okay, and especially youngsters. Any fast food restaurant, we see only youngsters are going, KFC, McDonald's, and they are opening left and right hotels. So you should take care of your health to prevent cardiac disease in the later. Most cardiovascular disease can be prevented by behavioral risk. Addressing that behavioral risk, factors like tobacco use, unhealthy diet, obesity, physical inactivity, and harmful use of alcohol. I'm sorry to say that alcohol use in younger generation is becoming more and more. I'm from Pondicherry. There are two so you know that, okay? Only two shops are famous in Pondicherry. Left and right, they open wine shops and a fast food restaurant. So I'm seeing that younger generation of, I cannot say that student because I'm sorry, but younger generation are moving towards there, okay? It has to be changed. And it is important to detect cardiovascular disease at the earliest so that we can modify the lifestyle, and if you identify the disease by community screening, and we can treat very effectively. So what are the common cardiac emergencies that we see? We know that acute coronary syndrome, acute heart failure, cardiac arrhythmias,
hypertensive crisis, aortic arch dissection, pulmonary embolism, infected endocarditis, cardiac tamponade, and cardiac tumor. So we are just going to, it is very, very, within 45 minutes, it's very difficult to cover all cardiac emergencies, but I'll try to justify the topic with these emergencies, what we see. So myocardial infarction, as we know, is a gradual rise and fall of biomarkers of myocardial necrosis like troponin and cardiac enzymes, plus ischemic symptoms, and development of patients will have symptoms. Then patient will go to the physicians. Physicians miss the case. He'll end up in problem. You understood? A lack of knowledge of identifying the cardiac emergency. So, if you see in rural areas, physicians will be busy in seeing 100 and 200 cases of OPD where you don't have time to do ECG, or he will not have a discussion with the patient. So, always when a patient comes to the hospital with chest pain, you have to make sure that there is not an ACS, that is acute coronary syndrome. Then you can safely discharge the patient. Why we want to do ECG? One is early recognition of acute myocardial infarction, appropriate treatment can be provided, and early recognition means early intervention. Time is muscle. It is not that if you diagnose myocardial infarction yesterday and do intervention 3 days after, you will get the same results. If you lose a myocardium, it is directly proportional to quality of life and longevity of life. Correct? If you suppose a patient has got ejection fraction of 65%, post-MI is ejection fraction, that is heart functioning is dropped to 25%. Definitely he is not going to survive whose ejection fraction is 65. Correct? So we have to identify the case and treat appropriately. So spectrum of ACS, it comes under 3 categories. One is unstable angina, non-ST elevation myocardial infarction, ST elevation myocardial infarction. This ST elevation myocardial infarction, it is known. Okay, that means what? ECG shows ST elevation, biomarkers will be positive. We know that, okay, this patient has got MI, immediately he has to send for reperfusion therapy, either by pharmacological therapy or by intervention. Problem comes with unstable angina and STMI. Unstable angina, patient will have ischemic symptoms, that is, patient will have chest pain, negative biomarkers, no ECG changes. So if we tell to the patient that he requires at least 4 hours, 5 hours observation to repeat ECG, or he requires admission, patients will not be willing for admission. Because why it is so? He cannot afford. Simply he cannot afford. For example, for a 3-day stay in a hospital, it costs some 15 to 20,000 rupees. Correct? Now it is bed charge and all, it's over. 3 days in M. So you just imagine. Now we are just moving towards the insurance claim, because insurance is very, very essential for everybody. Please, okay? You take health insurance is very, very important, because the cost of treatment is most of the people cannot afford cost of the treatment. So there will not be ST elevation in both NSTMI and unstable angina, but in NSTMI, positive biomarkers. So we can restratify the patient and send. Comes to unstable angina, once the patient comes to the hospital, this is the protocol that we should follow. That means chest pain. There itself, patients say, I cannot admit into the hospital. So how to go about? So you have to ask the patient to be under observation take an ECG and lab parameters, that is troponin. If ST elevation is there, then straight away ST elevation myocardial infarction, send the patient for revascularization. Then NSTMI, no STT changes, positive biomarkers, that also we can manage conservatively. Unstable angina, patient will have chest pain, no ECG changes, and troponin will not be elevated. So, unstable angina, next modality of investigation is stress test, which is contraindicated in ACS. So, we have a beautiful investigation that's called CT angiogram, which clearly shows this is a RCA, this is a LCX, and this is a LAD, which shows a lesion in the LAD. After that, we have confirmed with the coronary angiogram, but there is no complete occlusion of the lumen. Why there is no biochemical markers are not there? Because there is no evidence of myocardial necrosis. It is partially occluded vessel. If you leave it like that, then you will go for myocardial infarction. Then we can plan angioplasty. So, when patient comes to the hospital with ST elevation MI, brief physical examination in the emergency department, very important, ABC, that is airway, breathing and circulation. Vital signs and general examination is very, very important. Why it is important? Pulse and blood pressure. If the patient has got hypotension, patient is in cardiogenic shock. So entirely management is different. You have to take the patient for PCI. Presence or absence of JVP, that is patient is in congestive cardiac failure or not. Pulmonary auscultation for bilateral crepitation, that is patient is in pulmonary edema. This is very important. We means what, physicians who next to the bedside easily miss this cardiac auscultation murmur, which is very important. Usually post-MI, the patient can develop, within 2 to 3 days, the patient can develop papillary muscle dysfunction, ventricular septal rupture, that will lead to, or a free wall rupture of the ventricle, that will lead to mechanical complication. Okay? So, you can hear a pansystolic murmur when you hear very closely. Presence or absence of stroke, it is very, very important because we are going to thrombolize a patient, and if the patient has got any evidence of stroke, thrombolysis is absolute contraindication within the 3 hours time. So presence or absence of pulse, why it is important? Because aortic dissection can lead to asymmetry of the pulse, and that will lead to myocardial infarction if it involves a coronaries, and that is absolute contraindication for thrombolysis. You have to take them for surgery or endovascular repair. Presence of systemic hypotension, that is cardiogenic shock. So normal ECG does not rule out myocardial infarction. Our patient has got chest pain. If you do an ECG, if that is normal, you cannot send the patient saying that he is normal, because we have seen that 2 conditions, unstable angina, non-STMI. So ECG will be normal. So if the changes are seen in lead 2, lead 3 AVF, that is inferior leads, if you see changes V1 to V4, that is anteroseptal, if you see changes in the V5, V6 and lateral leads, that is lead 1 and AVL, it's called lateral. Changes means what? ST elevation or ST depression. ST elevation is myocardial infarction, ST depression is ischemia. I am talking about this. This is the ST segment, okay? Coming to acute coronary syndrome, ST elevation MI, the patient comes to you saying that he is having a crushing retrosternal chest pain. He says that, doctor, I am going to die. Please help me out. That's called impending death. Impending death. He says that and he keeps quiet because he knows that he is going to die. So, If you miss that ST elevation in the ECG, you are going to put your foot into the graveyard, office graveyard. You understood or not? If you miss the patient ST elevation in the ECG, you have to put your foot in his graveyard. Simple. So that is very, very important. That's why I'm again telling normal ECG, don't send the patient. Even the patient is having chest pain, you ask him to get under observation, do repeat ECG, then enzymes after 4 hours. Then in spite of that he is having pain, then you have to go for definitive investigation like coronary angiogram. Make sure that he is not having myocardial infarction. So when the patient comes to you with ST elevation MI, chest pain, onset of these symptoms, within 5 minutes, EMS team will come. Then encourage 12 lead ECG. This is very important. Consider pre-hospital fibrinolytic. That means what? How do paramedics will decide pre-hospital thrombolysis? That means they will take an ECG, to the telemetry they will send to the consultant. From there, hospital, he or she will guide you the paramedics. And in abroad and all, they used to thrombolyze in the ambulance itself. Okay? Because time is muscle. So symptom to needle time should be less than 30 minutes. Symptom to needle time, not to hospital to needle time. Here in India, what will happen? Patient will have symptoms, but he'll come to the hospital tomorrow, day after tomorrow. Okay? But symptom to needle time should be less than 30 minutes. Then triage the patient. That means what? PCI capable hospital. M is very lucky that we are having so many cath labs here, but in rural area they don't have cath lab. So not PCI capable, you do fibrinolytic, that is symptom to needle time is 30 minutes. If the patient if you are accessible for PCI, that means you can shift the patient for PCI, that is you can shift the patient for PCI if it is less than 90 minutes. You can see here, within 90 minutes. Symptom to needle time should be 30 minutes, less than 30 minutes. Symptom to balloon time is less than 90 minutes. After PCI, after thrombolysis, you have to transfer the patient to the hospital, inter-hospital transfer for PCI or CABG. That's called risk stratification. Because why I am saying after thrombolysis, 40% of the patient will go for reocclusion, again MI. So don't think that after giving thrombolysis patient we have saved. No. We have to do coronary angiogram for risk stratification, whether he has got a single vessel disease, plastable disease or triple vessel disease. You have to risk stratify the patient and do either PCI or CABG. What is this? Anybody? This is an ECG, simple, we will keep the discussion very simple. ECG, 12 lead ECG. What do you see? Anybody? You are able to see tall T waves, correct? Tall T waves. Okay? Previously we saw normal ECG, correct? So tall T waves indicates hyperacute MI. I am sure that our students, MBBS students, will miss this ECG. Okay? So if you miss this ECG, what will happen? Patient will go into acute myocardial infarction. So you have to catch the patient at this level and thrombolyze or risk stratify the patient, either PCI or thrombolysis. So this is acute anterior wall MI, STEMI. Same thing protocol. If you are able to do PCI, you can go for PCI, or if you are not able to PCI, less than 30 minutes, go for thrombolysis. See, MI comes with not only with ST elevation, correct? It comes with a complication also. What you see here, there is an ST elevation MI. You are able to see there is an ST elevation. And you can see that P waves are not following the QRS complex regularly. Correct? Usually P QRST complex. So P waves are coming on its own, QRS coming on its own. That means what? Patient is having complete heart block. Okay? And this is QS pattern. Very, very important. QS, first deflection is Q. That means what? Flush occlusion of the LAD. This is called widowmaker's artery. LAD is called widowmaker's artery. If you miss this case, or if you don't do intervention, a thrombolysis will not work. If you don't do intervention, patient ultimately goes into cardiogenic shock and we will lose the patient. So this patient has got ST elevation MI, on top of that complete heart block. Anybody? ST elevation myocardial infarction. What is the artery territory here? You can see that ST elevation in the inferior leads, lead 2, lead 3 and AVF. That indicates RCA infarct. So any RCA infarct, you have to do right side leads because the patient presents with the cardiogenic shock. No amount of thrombolysis will help. You have to replenish with IV fluids and improve the hemodynamics of the patient. Then you have to thrombolyze the patient or stent the patient. Same thing, ST elevation inferior wall MI with the atrial fibrillation. All these things, what you call adding fuel to the fire. Already there is ST elevation. If the patient has got complete heart block, you have put a temporary pacemaker. If the patient has got atrial fibrillation, then the patient will develop stroke. So all these things are very, very important complications that you will encounter when you see MI patients. So this is also complete heart. How it is different from anterior wall MI to inferior wall MI? 2/3 of the septum is supplied by LAD, whereas here RV branch is supplies a AV node. So if the patient has got a lesion proximal to RV branch, patient will present with the complete heart block with the ST elevation in inferior wall MI. So anterior wall MI, large muscle mass is involved if the patient has got complete heart block. Please make sure if the patient has got ST elevation in anterior wall MI with complete heart block, definitely he will have a very grave prognosis. This is very important. There is no inferior wall, there is ST elevation, but if you see here, there is a true posterior wall. So ST depression in anterior leads, V1, V2, V3, and inferior leads, there is an ST elevation. So it's a true posterior wall infarction. Again, patient will present with cardiogenic shock. You have to improve with IV fluids and vasodilators, vasopressors. So reperfusion option for ST elevation MI. So invasive strategy is a gold standard. Any patient who has got ST elevation MI, first and foremost you should offer is you have to go for PCI because that is a gold standard. Mortality is increased in those patients. So when you do invasive strategy, when the skilled PCI lab is available, that is symptom to needle time is less than 90 minutes. High risk STMI, that is if a patient is in cardiogenic shock. When the patient is have contraindication for thrombolysis and late presentation after 3 hours. If you thrombolyze a patient after 3 hours, invariably he will have IC bleed. And diagnosis of ST elevation in doubt. How diagnosis of ST elevation in doubt? Patient will have a ST changes, biomarkers will be negative, ongoing chest pain, then echo is normal. Then if you do an angiogram, then you can find out if a lesion is there or not. Okay? So what we do, we will cannulate this is an animation where you can cannulate the coronary artery, pass a wire. Over the wire, you have to pass a balloon and inflate the balloon and place the stent so that the lesion is covered. Okay? So this is an animation of the angioplasty. It is done in the coronary artery. It's called coronary angioplasty. So here we can see coronary wire in the RCA. And you can see the stent here placed. You can see the stent struts, netted one, stent strut from SNE from proximal to almost distal. So we can do angioplasty. If the patient does not offer angioplasty or the symptom to balloon time, if it is exceeding 90 minutes, then you should not wait, okay? You have to go for thrombolysis. What are the drugs which are used for thrombolysis? Streptokinase, TPA, retiplase, tenecteplase. It is very easy to use tenecteplase and retiplase in the sense 10 international units, half an hour apart, you have to give. Simple. So a patient will become fine. But only problem is it is expensive. How much it costs, 35,000 rupees. Whereas streptokinase costs only 2,000 rupees. At the cost of high risk, the patient will go for IC bleed. You have to explain everything to the patient, and you won't believe in our area, they cannot afford that also, because they are all daily wages. How much an auto man can earn per day? How much a richawala can earn? Okay? So they cannot afford that. So what we have to fight in the hospital, at least you have to store this and make it free for the patient. They will not do, that is different. Okay? So myocardial infarction. Okay? What are the complications of myocardial infarction? You can see that this is called Dressler syndrome, post-pericardial inflammation. We have seen already electrical instability, that is complete heart block, atrial fibrillation and other things. Papillary muscle rupture will lead to mitral regurgitation, acute heart failure, ventricular wall rupture leading to cardiac tamponade, cardiogenic shock when the large muscle mass is involved, stroke and embolism is a complication of atrial fibrillation, or it can complication of thrombolysis treatment. So all this you should keep in mind when you treat a patient with myocardial infarction. Anybody? So you can see here there is a flail interventricular septum. I will play it again for you. Flail interventricular septum, post-MI rupture, where you can see color also, color Doppler. Those who are doing cardiology postings, they can understand. Color Doppler, that is blood is going from left ventricle through the rupture interventricular septum to the right side. Okay, so this cannot be managed medically. Ultimately, patient will go into cardiogenic shock. So what you have to do angiogram, take the patient for surgery, repair the interventricular septum and do CABG. If it is the rent is very small, you can close with the Amplox device. Okay, if the rent is very big, there is no way that you have to take the patient for cardiac surgery. And mortality is high. Any patient who is going for surgery after MI, mortality is high. Sometimes patient can present very late. What will happen in our India? They will have chest pain. They will come a week later because they think that it is acid peptic disease, and they will go to physician and they will prescribe some medicines, and they will not aware of that. So what is this here? You are seeing a big left atrial clot which is attached to the LV apex. This can cause embolism and stroke. So mitral valve apparatus, mitral valve rupture, already we have discussed. It causes acute mitral regurgitation. Patient will be in cardiogenic shock. I am not going into detail about hypertensive crisis because that itself is a separate lecture. So you have to remember that the blood pressure 180 by 120, systolic 180, diastolic 120. With the organ involvement, it's called hypertensive emergency. Without organ involvement, it's called hypertensive urgency. If the patient has got hypertensive emergency, you have to bring down the blood pressure by all means to normal, because it is a progressive damage. And you can see that what are the organs involved here. If the patient presents hypertension encephalopathy, that is entirely different spectrum of management. Acute stroke, that is different. Intracranial hemorrhage, that is different. ACS, that is different. Pulmonary edema, according to tailor-made therapy. It is not that hypertensive emergency, you have to give the drug like that. So according to this aortic dissection, according to that you have to treat. Acute left ventricular failure is a constitution of symptoms and signs produced by complex circulatory neurohormonal response to cardiac dysfunction. Here, what we are representing as neurohormonal, sympathetic, and RAS inhibitor, RAS system. Okay. Heart failure is a complex clinical syndrome that can result from structural and functional cardiac disease that impairs left ventricular function. Impairs left ventricular, systolic function will keep, because acute left ventricular failure. So if you see, almost 70% of the patient will have left ventricular failure, 40 plus 30. One is acute left ventricular failure, and other one is again is going for decompensation. Hypertensive heart failure, cardiogenic shock, pulmonary edema, and right heart failure leading to left heart failure. This is very important. Phillips classification in acute myocardial infarction. If the patient presented with MI, no evidence of heart failure, class 1. And if you hear basal rolls up to half of the lung, and systolic blood pressure is more than 90, that is Phillips class 2, and frank pulmonary edema class 3, class 4 is cardiogenic shock. Why it is important? If the patient presented with the first and 2, okay, mortality can improve. When the patient comes with frank pulmonary edema or cardiogenic shock, if you don't intervene, we are going to lose the patient. So this is chest X-ray of the patient with acute pulmonary edema. This is called bat wing appearance. You can see here perihilar opacification or infiltration, that is alveolar opacity. That's called bat wing appearance in acute pulmonary edema. So what are the causes for acute heart failure? How do you manage? Okay. If the patient has got cardiogenic shock, yes, you have to look into pharmacological and mechanical therapy. If it is not, then you have to think over respiratory cause. The management is different, oxygen and non-invasive ventilator, CPAP or BiPAP. If that also is not there, then you have to look into what is the etiology of acute heart failure, that is acute coronary syndrome, hypertensive emergency, arrhythmias, acute mechanical cause, and pulmonary embolism, and appropriately you have to treat. Very important. So if the patient has got acute decompensated heart failure, the patient is hypertensive, vasodilators. If the patient is normotensive, you have to give diuretics. Then acute decompensation, pulmonary edema, that is severe pulmonary congestion with hypoxia, opioids, morphine. Only thing contraindicated is COPD. Please make sure, otherwise patient will go into respiratory arrest. Vasodilators, oxygen and non-invasive ventilator, and diuretics. Acute decompensated low output, that means hypoperfusion to the end organ. Already ejection fraction is 15-20%. Patient has already had an MI, then you give vasodilator, then inotropic support with small dose of diuretic. If you boost the diuretic, patient will go into cardiorenal syndrome. This is cardiogenic shock, acute MI. We have to treat with the inotropic support and mechanical circulatory device. Very, very important. So what is cardiogenic shock? That is inadequate tissue perfusion resulting from cardiac dysfunction. Clinical definition is decreased cardiac output and tissue hypoxemia in the presence of adequate intravascular volume. This is hemodynamic definition. Sustained blood pressure, systolic blood pressure is less than 90. Cardiac index is less than 2.21 ml per meter square. Pulmonary capillary wedge pressure is more than 15 millimeters of mercury. who are at risk for cardiogenic shock. This is very, very important. We know what is cardiogenic shock and we know that mortality is high. We want to identify the subset of patients who are at risk for cardiogenic shock. So, acute myocardial infarction, acute left ventricular failure. That is, when the patient is in pulmonary edema, he is in high risk. Mechanical complication, we saw one echo, VSD, papillary muscle rupture. We have seen that free-wall rupture, cardiac tamponade, and right ventricular failure. We have seen that inferior wall MI with RV extension. So we have to identify these patients. If the patient had cardiogenic shock for a long time, it is going to affect other system also, other kidneys. Patient will go into acute renal failure. Then it's very, very difficult to manage. So, Society of Cardiovascular Angiogenesis Intervention, that's called SCAI, stages of cardiogenic shock. We know that these patients are at risk of cardiogenic shock, okay, but hemodynamically stable, who is not experiencing any signs of cardiogenic shock. Then, patient is clinical evidence of hemodynamic instability, including that hypotension, tachycardia. Then classical, that is classical evidence of hypoperfusion, which requires pharmacological and mechanical support. In spite of that, he is deteriorating and patient has refractory cardiogenic shock. Easily remembered by A, B, C, D, and E. Which stage? A at risk, B as a beginning, we have to act at that level, beginning. If you miss that, then you'll go into organ hypoperfusion, acute renal failure, and we cannot revive. Once you suspect cardiogenic shock, with the available investigation at your center, M is lucky, you order anything, they will do. But we are not so lucky. We are working in the peripheral hospital, where pulmonary catheter and all we cannot do. So we take just a physical clinical examination, ECG, troponin. Pro-BNP also it's not available in our hospital. We are very poor. X-ray chest, echocardiogram. With this, we identify the patient, confirm whether the patient is having cardiogenic shock, see whether the patient has got acute coronary syndrome, revascularize the patient. Non-ACS, that is very, very important. If the patient has got non-ACS, that means what? It is not acute coronary syndrome, guidelines directed medical therapy. And if the patient has got myocarditis, then you can start the patient on glucocorticoids. Then if the patient has got pulmonary embolism, thrombolyze the patient. And pulmonary hypertension with RV failure, appropriate therapy. Then consider BAV, that is called balloon aortic valvuloplasty for cardiogenic shock. M has got, we don't have. Okay? Okay. So in spite of that, the patient has got hemodynamic support, then you can upgrade to LVAD and biventricular. LVAD means what? Left ventricular assisted device. So till now we have seen the coronaries, but patient can go for cardiogenic shock in post, what is this procedure? Percutaneous transluminal mitral commissurotomy, balloon mitral valvuloplasty. Following this, patient went into cardiogenic shock. What complication do you expect? Acute mitral regurgitation. Acute mitral regurgitation. Instead of tearing the commissure, we have tear the valve. So no way that any medicines will help this patient. He has to go for mitral valve replacement. What is this? Broken heart syndrome, youngsters. So this is called Takotsubo cardiomyopathy. Okay, stressful condition. Stressful condition where a patient will have some ECG changes and troponin will be positive. But if you do coronary angiogram, it is normal. Patient will have refractory cardiogenic shock. We have to treat with inotropic support. So take care of your heart, youngsters. So in cardiogenic shock, you have to, it is called mechanical circulatory device, which is higher end. Okay. So I will put in simple way. I used to go purchase my shirt, pant, non-branded items. Okay. Other people, they can afford branded items. Correct? Like that. Okay, if you are affordable, you can go for left ventricular assisted device. Now it is coming up with ECMO. If it is a myocardium is reversible, young patient, you have to treat the patient. Okay, so it is a reversible. Coming to cardiac tamponade, this is the triad that you should remember: distended neck veins, muffled heart sounds, and hypotension. So this is a triad you will see in cardiac tamponade. So patient will have increase in heart rate, jugular venous will be distended, muffled heart sound, pale mucosa, poor pulse quality, pulses paradox. And ECG shows electrical alternance and amplitude, where the amplitude can be changed and axis also will be changed. Why it is so? Because around the heart there is a fluid. Heart is moving inside the fluid. There is no constant electrical activity. You understood? So every time that axis will change, and each systole the amplitude will change. So X-ray shows cardiomegaly. Previously we used to ask undergraduate student, how will you diagnose pericardial effusion? With X-ray only. With this X-ray we can say it's a cardiomegaly. Correct? So radiology technicians, I can tell you, if the patient put on head down position and take X-ray, there will be superior mediastinal widening, so that will confirm pericardial effusion. What do you see in this echo? Where is the diastolic collapse of RA and RV surrounded by pericardial effusion. I'll play this video. You see? So where we cannot make electrical axis stable, so that's why electrical alternance, and the amplitude also varies. That's called electrical alternance. Immediately what we have to do? We have to do pericardiocentesis. I would like to share when I was there in hospital, where the physician has not called me for pericardiocentesis, we have lost the patient. I'm very sad, okay, because once you relieve the fluid, hemodynamics will automatically improve. So pericardiocentesis is a very, very important procedure. What complications can happen? What is this? What is this? Varanam Ayram, very good. No, somehow, see, the idea is it has reached to the targeted audience. I am happy about that. Okay? So this patient has had IV drug abuses. They'll have rot spots in the eyes, peripheral gangrene, septic pulmonary embolism, and right side heart, infective endocarditis. You can see here. Okay? So it's a case of infective endocarditis involving the tricuspid valve. Coming to hot topic, sudden cardiac death. What is sudden cardiac death? Please remember this. You read this definition, keep in mind. Okay? It's a natural death due to cardiac cause, heralded by abrupt loss of consciousness. Heralded by abrupt loss of consciousness within 1 hour of the onset of symptoms. Within 1 hour of onset of symptoms of an individual with or without known pre-existing cardiac disease. With pre-existing cardiac disease agreed. With or without. Please remember, okay? But the time and mode of death are unexpected. Time, mode of death is unexpected. So you have remember, I think, very easy. Okay, I'll go through again. Abrupt loss of consciousness, 1 hour of onset of acute symptoms, with or without pre-existing cardiac disease. Time and mode of death is unexpected. So he is addressing the retirement meeting. He is a manager of the bank. So he is addressing.
I should use that he has used for to make it a very happy retirement for you.
Happy
And
retirement.
simultaneously, I am very much thankful to Mr. Lalit, Mr. Tripathi ji, and all my colleagues that their blessing and their good wishes were with me, that I could see this very happy retirement today, graceful retirement today. No.
Papa?
Please, it's not a question of laughing jokes apart. You have to be very, very careful about this sudden cardiac death. And you should encourage your, what you call, near and dear, your friends to undergo health cares. Very, very important. Now, our India is the most, we know that last lecture we have heard about diabetes is a capital of, is more rampant in India. So it's one of the highest risk factor for coronary artery disease. So what is this? This patient has come to casualty with mild chest discomfort, not severe pain and all. You can see that V1, V2, there is T-wave inversion, okay? That indicative of ischemia. There is no infarct, no ST elevation, okay? So that is a very important sign in ECG. That's called Wallens syndrome. Okay, that is called Wallens syndrome. So just about to disconnect her, she told that she is experiencing severe pain. This has happened. Just minutes after this was published in NEJM. Minutes after, not even minutes, within 2-3 minutes only, just disconnecting, and again she had got pain. Then luckily they have she did another ECG which showed that ST elevation. That's called shark fin sign. Shark fin. You can see that ST elevation here. Okay, ST elevation, shark fin sign. Very important. Okay. And one more ECG is very important. There is no ST elevation. It's only ST depression. Correct? ST elevation in AVR indicates triple vessel disease. ST elevation in AVR indicates left main disease or triple vessel disease. So, did an angiogram. Angiogram shows, here you can see that left main and also LCX, he has got a disease. We cannot thrombolyze this patient immediately. Yes, we have to go. If you that is a catheter, Judkins catheter, if you introduce into the coronaries, that will cause dampening of the circulation and you have cardiogenic shock on table. So you have to take the patient for either CABG or angioplasty. Anybody? Arrows are there. S1, Q3, T3. In ECG, pulmonary embolism. So I'll again play a video for you. You can see that mobile clot is there in the right atrium. RA-RV is distended and RV apex is hyperkinetic. That's called Meckelon's sign. And RA-RV is dilated and there's a mobile clot in the right atrium. Okay, it has migrated from the foot to heart. Okay, and we did a CT angio. CT angio shows pulmonary embolism in the main artery and also left side and also right side extending into the pulmonary artery down there. So when you diagnose pulmonary embolism, so if the circulation is severely impaired, hypotension, then you have to do thrombolysis or embolectomy. If the patient is stable, then you have to do heparin therapy, anticoagulate the patient. If anticoagulation is contraindication, then you have to put an IVC filter. Again, for you. That person, focus on that person. 29. Some are familiar with cardiac resuscitation. So that is failed resuscitation. Previously we saw one cardiac arrest that may be having a risk factor, but he is an athletic. Okay, so in hypertrophic cardiomyopathy, we will miss hypertrophic myopathy with concentric left ventricular hypertrophy. Sometimes we need an CMRI, that's cardiac MRI, to look into apical cardiomyopathy, which easily you can miss. Okay, so this is a hypertrophic cardiomyopathy. Echo will see the interventricular septum is thickened, and SAM, CMRI, which shows apical cardiomyopathy. So you have to be very careful when you certify the patient. And the treatment is septal ablation, alcoholic septal ablation. You can see here, this is a first septal artery. With the alcohol, we have ablated the septal artery to reduce the thickness of the interventricular septum. So what are this constitutional, what combination can occur in this patient? Tall stature, high arched palate, wrist sign, thumb sign, hyperextensibility, arachnodactyly. Anybody? It's called morphonoid habitus, Marfan syndrome. Okay. So what complication can happen here? What do you see in this video? This is a suprasternal view, where you can see the dissection of the aorta. You can see here undulating membrane in the arch of the aorta. Okay, and associated with acute AR. Color Doppler shows acute AR, and you can see that undulating aortic, that is intimal dissection. Okay, no way, no medicines can help him. He has to go for cardiothoracic surgery, where they will do aortic valve replacement with the aortic arch replacement with the repositioning of the major vessel. That's called Bentall's procedure. I am happy that I have referred one patient here with triple M. Professor Rajan sir has operated and is doing fine, is coming for follow-up. As we already discussed, what is this? Patient has got dense calcific aortic valve. You can see the gradient across the aorta is high. So as long as the left ventricle is normal, there will not be any problem, but the calcification will progress. Patient will have a left ventricular hypertrophy, and the patient will have left ventricular dilatation, and sudden cardiac death can happen because of myocardial fibrosis. So coming to ventricular tachycardia, sustained, non-sustained, monomorphic, and polymorphic. We will not go into detail, we will go detail with the ventricular tachycardia. If it is sustained, more than 30 seconds or hemodynamically unstable. If it is non-sustained, less than 3 beats, but hemodynamically stable, and heart rate is around, ventricular response is more than 100. Monomorphic, all QRS complex is same. Polymorphic, varying QRS complex. So this, I think we can skip how to identify all those things. This is a ventricular tachycardia. You can see all the complexes are same, wide, bizarre, complex, with the positive or negative, it is negative concordance. So this is ventricular tachycardia. So in the setting of acute MI, patient is having ventricular tachycardia, so you have to treat the patient. So ventricular tachycardia, it will not be like ventricular tachycardia. Like your friends are there, okay, it will not be like that. You will have changing characters, okay. At that time, if you spend, okay, he will accept. He will not spend, like that. Ventricular tachycardia will degenerate into ventricular fibrillation. Okay, it's very, very important. You have to swiftly, immediately respond the patient with cardrone therapy. Or if the patient goes for ventricular fibrillation, you have to act within minutes. You can see here, If you revive Rose, that's called circulatory system, reverse circulatory, 80% of chances can occur in within 2 minutes. If it goes to 4 minutes, only 60%. If it is 8 minutes, only 20%. Okay? You understood? Most of the duty doctors, what they do in the night, they will sleep. Okay? So, you should be very careful. Okay? And this is, you can see this is an ST elevation, but patient is not having any chest pain and he walks into the, your consultation room. This is called channelopathies, high risk for sudden cardiac death. This is called Brugada syndrome. You have to put in Holter monitoring, see whether the patient has got ventricular tachycardia and treat the patient with anti-tachycardia device, that is AHCD. So this is polymorphic ventricular tachycardia which occurs in QT prolongation. Again, young patient, channelopathies, you have to put the patient with the ICD, or intracardiac device. This is arrhythmogenic right ventricular dysplasia. Again, patient will go for various complications, that is tachycardia. Then you have to treat with pacemaker. This is anomalous coronary artery, which we published in our hospital, where LAD arising from RCA, patient is having constant chest pain in spite of adequate treatment. So we did an angiogram, and CT angiogram shows this is RCA, and this is a LAD which is arising from RCA. It goes into the anomalous course. The patient will have experienced chest pain. That is also one of the cause for sudden cardiac death. So not only tachycardia will present sudden cardiac, even bradycardia also is very important. Sinus node dysfunction and atrial tachyarrhythmia, atrial fibrillation, atrial flutter, you have to take care. All this can happen in tachybrady syndrome. If you analyze with the 24 hours Holter monitoring, you'll have atrial flutter, atrial fibrillation, sinus pause, where the patient will go into cardiocerebral imperfusion and patient will have syncope. This second degree AV block in the setting of MI third degree requires temporary pacemaker and revascularization. What is this? Common electrolyte abnormality that you will encounter is hyperkalemia. Why? This is called sine wave. Sine means yes, he is signing off. He is signing off from ground. Okay? So you have to intervene immediately. There is no question. You have to put a temporary pacemaker, calcium gluconate, and salbutamol nebulization, insulin and glucose therapy. All these things simultaneously you have to say to acquire the sinus rhythm. And we have discussed about up to trauma. This is a cardiac tumor. Anybody? Left atrial myxoma. This is called left atrial myxoma. What is the importance of this? It can cause showers of embolism into the systemic circulation and produce stroke. So it has to be operated as early as possible. So cardiac emergency checklist. Whenever you are there in the EMS team, or you are a part of EMS, you cannot escape cardiac emergency, any branch of you cannot escape this cardiac emergency. So if the patient has got hypovolemia, you have to treat hypothermia, hypoxemia, hypo and hyperkalemia, acidosis, cardiac tamponade, toxins, tension pneumothorax, pulmonary embolism, and coronary artery thrombosis. 5H and 5Ts, very, very important. So point of care ultrasound in cardiogenic shock. So it is a recent advance in cardiogenic shock. One person will be resuscitating. This is a compression drone, and we have to circulate the probe, ultrasound probe on different angle. You can see that, and get the images so that suppose the patient has got cardiac tamponade. If you keep on compressing, there nothing will happen. You have to do pericardiocentesis. Okay. This is a multi-targeted ultrasound and a single targeted ultrasound. Usually in trauma, you will miss all these things. We'll be concentrating only on vitals. So a patient has got trauma with blood in the peritoneal cavity and hypotension. If you miss that, we are going to lose. For suppose a long bone fracture. soft and soft tissue, long bone fracture, you will miss the patient. Okay? So this cardiac arrest, trauma, non-traumatic shock, dyspnea, chest pain, all can be assessed with the multi-target ultrasound examination. It's an upcoming field now. So we have come to last slide. So as we are discussing why this tertiary care hospital are flourishing, all patients are coming with acute illness, correct, stroke and other things. Tertiary care hospital is taking care of them. Secondary care, management of acute episodes, worsening of chronic disease, you have triage. Primary care is again, that is risk factor management. Public health promotion, it's very least if you see this. So we have to flip this inverted pyramid. Flip means what? Just flip it. So this is a one. Public health promotion is very, very important. Primary care setting, that is control of blood pressure, as morning Dr. Ganesha has pointed out. Blood pressure and blood sugar management, smoking cessation, and the secondary care will come down and the burden will come down on tertiary care. Thank you for patient listening.
Audience can put forward your queries.
I know a lot of questions will be there. Happy to answer. Till now, I thought the hall will be silent after my lecture. So at least everybody should educate your near and dear circle about healthcare. That will be the take-home message for this lecture. Okay, everybody in the medical field, so you should take care of near and dear and promote health awareness.
Thank you very much, sir, for sharing your deep knowledge.
So
now I request our principal.
From my side, I can ask only one question. Avoid fast food, junk foods, youngsters. Okay.
Now I request our principal to honor Dr. Badrinath with a memento. Thank you, sir, and thank you, ma'am. Ladies and gentlemen, it's time for the lunch break now. Enjoy the meal. We'll resume here back.
Students, please be seated in your place. As it is a patient area, we'll be sending you in an organized manner. So please be seated. CHS students can wait for the lunch. After other colleges have finished their lunch, you can go for the lunch. So first 3 rows from each side can go through the entrances nearby. Please, people in this side, please, you can wait. The other side can move. You please sit down. Three rows from this side can move. Students and lecturers who are participating in oral paper presentation, please report to the comparing desk.